Hey everyone, we have another superb case study for you today. This patient has low back pain. Can you work out what's going on? Join us for the assessment, the diagnosis, and all the clinical reasoning. So if you're ready to learn, let's dive in. Hey everyone, Khalid here. Welcome back to Clinical Physio. Today we've got another patient case study. This patient has low back pain. If you enjoy this video, please be sure to smash that like button. And otherwise, let's dive in with this case. So first of all, let's look at the subjective history. We have a 35-year-old male who's presenting with a 1-week history of lumbar spine and right-sided leg pain. His leg pain is going all the way down from his buttock posteriorly all the way down to the foot. It started 1 week ago and he really isn't sure why. There was no clear, obvious reason for why these symptoms started. What is he feeling? Well, he's experiencing naturally a lot of pain in his back, but more so the pain in his leg. And he feels an element of weakness in his right foot. He feels like he lost the power pushing through his foot. So when he wants to push himself to go up the stairs, when he wants to push through his foot in order to walk, he's unable to do so because it feels much weaker than the other side. He also has an element of tingling on the outer part, the lateral side of his right foot. So he clearly has some neurological symptoms going on. He's also got some additional symptoms which are quite peculiar. He has 4-day history of numbness around the proximal inner thighs, so just around where his underwear would normally be. And he also explains that he's been noticing some differences in his toilet habits. When he's trying to go to the toilet to pass urine, he feels like it's a little bit difficult to do so. And he also finds that on occasions, it almost feels like he's been leaking. He almost noticed that he's had some wetnesses in his underwear without really being sure how it got there. So there are some concerns with this individual. He's quite worried about the symptoms that have been going on in the last week. And I can't blame him. I can understand just why he would feel that way because it doesn't sound like a very good picture. Okay, so next let's look at the objective examination for this patient. First of all, it's clear that he's in a lot of pain. Both walking in, you can see that he's in a lot of pain. He walks with an antalgic gait, i.e. a gait that feels painful for him and he's limping as a result. We also know that he's got that weakness that he feels in his foot, and that's apparent on walking as well. We then look at lumbar spine range of movement, and unfortunately there really isn't very much. It's very painful in all directions. We then look at the hips, and we do find that there's some restriction in hip movement on both sides with hip flexion and external rotation. However, always important to do for when you're clearing the hip, ask your patient, where does your pain hurt? Does it hurt at the hip or at the back? And when you're doing the hip movements, he isn't reporting hip pain, he's reporting back pain. So it's clear that moving the hip is actually hurting his back, probably because of the way that the pelvis is moving and the way some of the muscles are moving when he's doing those movements. It isn't hurting in his hip when you do the hip movements. We then do a neurological examination. We look at the dermatomes and it feels like it's numb on the S1 region of the right foot. That's the lateral side of the foot. And when you go through myotomal testing, we find that there's this clear weakness in the S1 myotome on the right side. And the S1 myotome is for plantar flexion, which makes sense. That's in keeping with his difficulties that he feels pushing his foot down to the floor. We also do his lower limb reflexes. We do the knee jerk on the right and left sides. We do the ankle jerk on the right and left sides. And on the right side, it's clear that the ankle reflex is absent. There's no reflex there. We also do Babinski and Clonus reflexes as a part of an upper motor neuron lesion screening. Thankfully, that doesn't show any abnormalities. But the fact that he has the absent ankle reflex on the right foot is certainly something we have to be aware of. So, key questions for me to ask you. Number 1, what do you think's going on? Number 2, what would you do? How would you manage this patient case? Here's your opportunity to pause the video, write down your thoughts, and join us again in a second. Okay, everyone, time's up. Let's look through this patient case. So, unfortunately, this patient presented with quite clear symptoms of cauda equina syndrome. This is a condition that all clinicians don't want to see in their clinic because it's a major emergency. The cauda equina is the bundle of nerves at the distal end of the spinal cord, controlling the nerve supply from L2 to S1, which basically means all the supply to the legs, but also to our private areas and our reproductive organs and our toilet organs, both for bowel and bladder. So when a patient is presenting with a compression of those nerves, we unfortunately get symptoms consistent with what this patient had. Number one, pain in the legs or symptoms within the legs, and we can see that he has the weakness in his foot and also the numbness in the foot. But more importantly, that really highlights the cauda equina syndrome element was those bladder changes and the numbness around his private areas as well. So you will have noticed that he was experiencing occasional leakage where he feels like he's not able to control the urine flow and he feels like he's been noticing random wetness in his underwear, but also the saddle anesthesia. Now, saddle anesthesia is where we have numbness around our private areas, but it's really important to say that that doesn't just include the genitals, it also includes the upper aspect of the thigh and also the buttocks, because those areas are all controlled with sensation by the cauda equina. So it's always important to clarify when you're asking about saddle anesthesia, ask about all those areas, the genitals, the buttocks, and the very top of the thighs. And the very top of the thighs was where this patient was experiencing some sensory loss as well. So what do we do about it? What should we do about this patient? The key thing we need to do here is refer the patient immediately to the emergency department. Now, here in the United Kingdom, we have a really good set of criteria called the GIRFT guidelines, getting it right first time. And if you type into your internet search browser, getting it right first time or GIRFT, cauda equina guidelines, these will easily come up. What these guidelines effectively say is that if your patient is presenting with signs consistent with cauda equina, like the significant worsening, like the saddle anesthesia, like the bladder changes, with a less than 2-week history, they should go immediately to A&E. And that's exactly what was the case for this individual. And as you can see, what we have at the bottom there, the key indications as to why: the bladder incontinence, the saddle anesthesia, the worsening neurological pain, and the worsening neurological function of the myotomes, the dermatomes, and the reflexes, because he had that ankle reflex that was diminished, as well as the fact that these symptoms are very, very acute. They've been experienced for less than 2 weeks. So once again, all the key indications that unfortunately this patient has cauda equina, but that by referring them to A&E, we're getting them the best treatment we can. So if you've enjoyed this case study, please support us by smashing that like button. It's the number one thing you can do to help our channel. And remember, we've got more brilliant resources on our Instagram account at Clinical Physio. Give us a follow there for more brilliant content for physiotherapists. And of course, we have even more with mainstream webinars on our membership platform, member.clinicalphysio.com. There we have webinars such as lumbar spine red flags, lumbar spine red flag case studies, MSK red flags, and we also have the Case Study Club, a brilliant resource where if you like learning by case studies, we have all the tools for you. So thank you so much for watching. My name's Khalid. See you soon here on Clinical Physio.